Hello everyone. November 14 was acknowledged annually as World Diabetes Day worldwide. The date of November 14 was not chosen by chance. It was on this day that Frederick Bunting, a scientist who discovered insulin, was born. World Diabetes Day is acknowledged in the world since 1991 with the support of the International Diabetes Federation. In humans, insulin is produced by the beta cells of the Langerhans islets of pancreas. Damage to these cells decrease insulin production and develops type 1 diabetes, while type 2 diabetes develops due to impaired cellular receptor sensitivity to insulin. Both types of diabetes are manifested by the high blood sugar levels, that is hyperglycemia, which without proper treatment it can be life-threatening. Methods for the prevention and even early treatment of type 2 diabetes include correction of body mass index, physical activity, and reduced consumption of carbohydrates with high glycemic index. The only effective treatment for type 1 diabetes is lifelong insulin replacement therapy. I am Smriti, a second year MSc Nursing student of Sri Gokulam Nursing College, and in this presentation we will take a quick look on basics of insulin therapy, that is types, regimen, storage and injection technique, safer and friendly insulin delivery, that is insulin pen, adapting better practices, that is insulin dosing and newer analogs. First we can move to the physiological secretion of insulin. Basal insulin secretion occurring in regular pulses, that is independent of blood glucose concentration, accounts for about 50% of total daily production. Available exogenous insulins are human insulins and insulin analogs. Human insulins include regular insulin, that is atrapid, NPH insulin and premixed human insulin. Insulin analogs include rapid acting, long acting, co-formulation and premixed insulin analogs. And here you can see the examples of each type. Insulins are available in two strengths, 40 IU and 100 IU. 40 IU are Mixtard 50, Mixtard 30, Atrapid and Insulatard. 100 IU are Levemir, Tresip, Novorapid, Fiasp, Mixtard 30, Novomix and Rysodec. Based on strength of the preparation, dose of insulin is measured in IU, that is international units. In most Western countries, only 100 IU insulin is available, whereas both 40 IU and 100 IU insulins are used here. Here you can see the onset of action in hours and peak effect in hours and duration of action in hours of different insulins. Next is about rotation of injection site. As you all know, insulin is injected subcutaneously, which means into the fat layer under the skin. In this type of injection, a short needle is used to inject insulin into the fatty layer between the skin and the muscle. Insulin should be injected into the fatty tissue just below the skin. If the insulin is injected deeper into the muscle, the body will absorb it too quickly. It might not last as long and the injection is usually more painful. This can lead to low blood glucose level very fast. People who take insulin daily should rotate their injection sites. This is important because using the same spot over time can cause lipodystrophy. In this condition, fat either breaks down or builds up under the skin, causing lumps or indentations that interfere with insulin absorption. You can rotate to different areas of your abdomen, keeping injection sites about an inch apart. Or you can inject insulin into other parts of your body, including thighs, arms and buttocks. And in this figure, you can see the different areas that should be used for the injection of insulin. You can also rotate within injection sites. In these pictures, you can see the different patterns that can be used during an insulin administration. That is horizontal pattern, curve pattern, zigzag pattern and crisscross pattern. Another important point to remember is do not rub the injection site. Do not try to massage the area where you inject insulin and not to exercise that part of your body after injection, because it may cause a sudden drop in the blood sugar. Next is about the skin fold. Any insulin injected into the muscle will be absorbed too quickly into the bloodstream, which may result in high variability of blood glucose levels and increased risk of hypoglycemia. Injecting into muscle is also known to be more painful and might cause bleeding and bruising. To avoid injecting into the muscle layer, it is important to use a short pen needle and if necessary, use a lifted skin fold. High variability in blood glucose level will increase the risk of hypoglycemia. And in this picture, you can clearly see how a skin should be folded for insulin administration. Next point to remember is remove the needle from the pen after injection. Always remember to remove the needle from the pen after injection. That is, the main purpose is to prevent air entry into the cartridge as well as leakage of insulin. Temperature and pressure changes may cause air bubbles to form in cartridge when cold and to prevent the leakage of insulin out of cartridge when hot. Leaking pre-mixed insulin can derange mixture ratio and this can lead to incorrect mixture and dosing. Next important point is do not reuse the needle. Reusing the needle may cause bleeding, bruising or scarring. It also leads to breaking off and lodging of needles under skin. There is higher chances for insulin getting deposited within the needle and it will be harder to press on plunger and deliver proper insulin doses. It also increases risk of contamination and infection and it can also lead to lipohypertrophy. Next point is do not inject through clothing. Many patients inject through clothing, particularly if they are in a hurry or unable to disrobe in public. However, this practice should be avoided. The needle can become unsterile and cause infection. Its lubrication can be lost, potentially causing pain. Clothing fibers can enter and irritate the skin. It also prevents the lifting of a skin fold or visualization of the injection site. Next is about the insulin storage. Unused insulin pens, unused cartridge and vials should preferably be refrigerated in 2 degrees Celsius and 8 degrees Celsius. It can be used till the expiration date provided by the manufacturer. Never be allowed to be frozen and if frozen, it should be discarded. Keep insulin in a place within the refrigerator which is distant from the deep freezer compartment. Storage of insulin during travel. Stored in an insulated bag or cooled thermoflask with ice if the ambient temperature is expected to be higher than 30 degrees Celsius. Insulin should not be kept in a locked car with closed windows. While traveling by air, insulin should not be placed in the checked-in baggage to avoid exposure to extreme temperatures, that is mostly freezing. Right way to store insulin is there will be no special requirements in case of humidity and it should be protected from direct sunlight and strong artificial light. It is important to protect insulin products from wet conditions such as rain, sleet and snow. Follow arrows or any other marks that indicate correct orientation and never send or keep insulin products together with dry ice. Basic methods of insulin delivery, that is syringes and vials. The drawbacks of the basic method of insulin delivery using syringes and vials are cumbersome, difficult to transport, inaccuracy in withdrawing the correct dose of insulin, difficulty in mixing insulin wastage, stigma of injections and needle loses sharpness that may cause more pain. Using of vials and syringes are more complicated, time consuming and error prone. It also leads to less accurate dosing, lower compliance, more injection pain and embarrassment and social stigma of using in public. Even trained users can make dosage error. Next is about the insulin pens. The pre-filled and durable pens improve convenience and ease of use, more discreet, more accurate, more preferred and switching from vial and syringe associated with improved adherence. The needles of insulin pens are less painful and easy to attach and detach. Using an insulin pen can reduce the risk of needle stick injuries and their associated cost. Here you can see the incident rates of needle stick injuries. Changing from conventional vial or syringes to insulin pen decrease the incidence of needle stick injuries. Next is about the type of insulin pen. There are two types. First one is reusable pen and the next one is pre-filled insulin pens. Reusable pens are also known as permanent or durable pens, and pre-filled insulin pens are also known as temporary or disposable pen. Reusable pens, there is replaceable refill, more economical and durable, and pre-filled insulin pens are inbuilt single-use insulin device which is convenient and easy to use. Next is about the main characteristics of Novo Pen 4. It is accurate dose delivery for 5 years, low force to inject dose, easy dose adjustment and easy to read dose scale. Flex Touch, the next generation pre-filled or disposable pen. The characteristics are accuracy and consistency, that is accurate and consistent dosing. Dose force, the significantly lower dose force than any pre-filled pen. The preference is significant preference versus Solo Star and Quick Pen. Ease of use, significantly easier to use than Solo Star and Quick Pen. Efficacy and safety is about equivalent efficacy and safety as Flex Pen in clinical trials. Insulin resuspension, dial and inject. Dial, turn the dose selector to select the number of units you need to inject. The dose can be corrected either up or down by turning the dose selector in either direction until the correct dose lines up with the pointer. Inject the dose by pressing the push button all the way in until 0 lines up with the pointer. Keep the push button fully depressed and let the needle remain under the skin for at least 6 seconds. Common approaches to insulin dosing in non-critically ill. Basal insulin dosing with prandial and correctional doses. Sliding scale insulin approach will lead to inadequate control of hyperglycemia, high rates of hypoglycemia, longer hospital stays. Do not allow for basal or mealtime insulin requirements calculation. Grossly underestimate total daily insulin requirements. Respond to hyperglycemic after it has happened rather than preventing it. Depends on the inaccurate assumption that insulin sensitivity is uniform among all patients. 3 components of insulin administration in the non-ICU hospitalized patient include basal insulin, nutritional or bolus insulin and correctional insulin. For most patients in the hospital, basal bolus is the preferred regime. Premix insulin, which can be continued if patients have been well controlled previously and these patients require frequent monitoring. GLP-1 analog can be used if there are no contraindications to insertins. It helps to reduce the total daily dose of insulin and minimize the risk of hypoglycemia. Next is about the FASP, that is fast acting insulin aspart. The fastest insulin, which closely mimics normal physiological insulin response and so fast that it can be taken after meals. It provides a faster insulin response compared to Novo Rapid. It is an insulin that could be given post-meal, offers the convenience of calculating the dose based on patient intake. Clinical applications of fast-acting insulin aspart is basal failure, gestational diabetes mellitus, preoperative, perioperative and postoperative patients and in hospitalized patients. Newer insulin analogs, the right choice in hospitalized patients. The challenges addressed by FASP is flexible dosing of 2 to plus 20 minutes with shorter duration of action almost mimicking physiological insulin. No dose adjustments required in elderly, that is less than 75 years, renal and hepatic impairment, metabolized by internalization and approved in pregnancy. Flexible dosing of -2 minutes to plus 20 minutes with shorter duration of action almost mimicking physiological insulin. The fast-acting insulin aspart, that is FASP. It helps in better control of hyperglycemia. It is safe and easy to use. The first characteristics is faster and effective. Fast-acting insulin aspart provides greater early glucose lowering effect and better PPG control. It is safe. It is approved and safe in hospitalized patients, pregnancy, pediatrics, renal and hepatic impairment, and pumps lesser rates of severe hypoglycemic episodes. It is flexible and easy to use. The suggested initial dose is 4 units at one or more meals. Flexible post-meal dosing, that is fast acting insulin aspart, can be administered before a meal or up to 20 minutes after a meal. So this is about my class, and I hope all of you had understood about the insulin pens. Thank you.